organizers, especially Dr. Love, giving us the opportunity to chair these sessions. As all of us know, increased incidence of hepatitis C virus infection are due to increased awareness and increase in the appropriate investigations. In clinical practice, there is no such history of blood transfusion or intravenous drug abuse. Still, we see a lot of hepatitis C virus infections. As physicians are in dilemma, how are we to proceed? Next, we see a lot of cases presenting with extrahepatic manifestations. So this is a very useful and important topic for all of us. I request Professor Dr. George M. Chandy to talk on management of hepatitis C virus infection neonates. Professor Chandy, please.
Respected chairpersons, members of the Indian Society of Gastroenterology, our surgical colleagues, and dear friends, ladies and gentlemen, I want to thank the Tamil Nadu ISG Salem branch members for this privilege of sharing with you some thoughts on a rapidly evolving field. And in the next 15 to 20 minutes, I'll try and do some justice to a topic where there's so much to talk about and there's so many developments, as our chairperson rightly said. Originally, it was a non-A, non-B, reported initially in 1982, maybe a reportable disease, isolated and characterized in 1989, where 3% of the world's population, we talk about 0.8 to 1% in India, and over 3.9 million people in the United States infected. Leading cause of chronic liver disease, cirrhosis, and the need for liver transplantation. We know about the HCV genotypes and subtypes, so I won't go into it, the 6 major genotypes and the subtypes that are being described now. So the goal of therapy in trying to treat chronic hepatitis C virus infection is to try and eradicate the virus. But there are lots of other additional goals: slowing down the disease progression, minimizing cancer, improving the liver histology. So fibrosis, cirrhosis, prevent decompensation, prevent HCV. So in 2001, the standard of care became the combination of PR, so to speak, PEG interferon with ribavirin. So we saw that with interferons, what we managed to do was, there was the first phase of rapid decline in good cases in the first 1 to 4 days, and a secondary response due to the production of certain enzymes, a second phase of several weeks to months, mainly because of a secondary immune response, causing apoptosis of the HCV-infected hepatocytes and the prevention of HCV entering new cells. Now, ribavirin became very essential with a role of antiviral activity and mainly in the prevention of relapse. So when you added ribavirin with the interferons, you find, as you see here, suddenly there is a significant improvement in the early response as well as in the sustained viral response. So what we have now is a treatment schedule. Initially, when it was just interferon alone, it was 6 to 12% sustained viral response. When we did PEG interferon alone, 30 to 50%. And in most of our patients now, which are Geno 2, 3, or mainly 3, we have even up to an 85% response. So why aren't we happy about this? Whole lot of contraindications to treatment, a whole lot of patients we have to avoid, mainly because of either complications or because of problems where we cannot treat them with. Several interferon-related, interferon-induced or exacerbation of diseases, thyroid disease, diabetes, rheumatological disorders, interstitial pneumonitis, hematological disorders, and autoimmune hepatitis. So when you look at the side effects of this treatment, a whole lot of side effects. Mainly it's the flu-like symptoms, the asthenia, depression, anorexia. And you know the patients whom you have treated are generally not the happiest of people. I just want to quickly look at words that you know, but just to revise with you. The RVR, which is the rapid virological response, that where the virus becomes undetectable in 4 weeks. The EVR, which is the complete early virological response, undetectable after week 4 and even up to week 12. The slow to respond, the STR. So the utility of the rapid viral response is that multiple analysis suggests that when there is a rapid virological response, much more chances of a sustained virological response. And the complete EVR, that means when there is complete early virological response versus partial EVR, gives you answers right at the beginning as to what your patients are going to do when you treat them. Take the SVR, that means a sustained virological response. When you have a good rapid response and early response, your responses in terms of sustained virological response becomes much, much better. So the sustained virological response is based on 2 separate independent steps. One is it must respond virologically and achieve an undetectable HCV RNA level, and that's dependent primarily on the PEG interferon. And to prevent the relapse, it's mainly a function and action of ribavirin. Now, for the sustained virological response, there are lots of potential benefits, as you can see, mainly in terms of preventing progression to cirrhosis and hepatocellular carcinoma. So you have a whole lot of names, like the chimpanzee tries to say he had an RVR but not an EVR, or an RVR8 because he developed RAVs and so that he got an EVR. A whole lot of terminology. Actually, we don't really need to worry about it. So when you look at the pattern of response, what is important is to see whether there is a rapid response by week 4, an early virological response, end of treatment, and then after another 24 weeks, look at sustained virological response. And when you look at this picture, for example, the patient on treatment, all these show the early response versus the slow virological response. And to remind ourselves about the breakthrough, which can happen while on treatment, while relapse is at the end after the treatment is over, when you're watching for the next 24 weeks, if there is that is what is called a relapse. So the time points mainly are at week 4, at week 24 when it is end of treatment, and week 48, which tells you the sustained virological response. Now, the longer duration of undetectability of the virus increases the chance of a sustained virological response. So what are all the predictors of response? There are the viral factors, which is the genotype and the quantity of the RNA, and a whole lot of patient factors. And now the newer identified IL-28B polymorphism and factors that are related to on-treatment factors. So when we started, we had the SVR rates with standard interferon, which was very low, and then with ribavirin initially we got something better. And now in patients who are genotype 1, this is the kind of response we get. While with genotype 3, which is what we see, we are getting up to 80-85% response. So the standard of care that we follow gives us, with the treatment available now, what we all follow now with PEG interferon and ribavirin, we are getting good response, as you can see. Now, what about the utility of the rapid viral response? In this Accelerate trial of nearly 1,500 patients, they found that a 24-week treatment is superior to 16 weeks, but if the patients can't tolerate it, you can truncate it to a 24-week course. So the AASLD guidelines and the EASL guidelines tell us now that PEG interferon alpha 2A or 2B, along with a dose of 800 milligrams ribavirin, gives a planned treatment in our patients, which are genotype 3 for 2-3 for 24 weeks, gives us the best possible results as it stands. There are a whole lot of guidelines for managing patients who are non-response or null response, partial response, and those we are watching out for those who have missed doses, who have a null response as well. This is one of the more interesting things that has developed of late, the host genotypic response, the IL-28B polymorphism, where the genetic polymorphism near IL-28B, which encodes for the interferon lambda 3, the CC genotype very strongly correlates with a good positive response. So this is something that has really brought further hope in our treatment. So just look at this cartoon where patients with the IL-22B subtype CC, we get up to 87% response. The response rates in this trial with genotype 1 treated with PEG interferon or ribavirin, just look at this one. Excellent response up to 80%. So in 2011 or 2012, where are we? We are getting more and more newer ideas, mainly because of those that can directly act on the virus. So just look at this cartoon where you have the virus entering through the receptor binding sites. The endocytosis takes place as fusion and uncoating. And when you come out here, what happens is you have the negative strand and the positive strand. It's this negative strand that helps to encode. There is no DNA in between. It is the RNA strands up to 10 replicates. And then that is where we are able to work with the NS3, NS4 protease inhibitors or the NS5B polymerase inhibitors. All of them, and the whole list of new drugs that have now become available. The main ones for us in phase 3 now are the boceprevir and the tenofovir, and a whole lot of unpronounceable names, but you will hear about danoprevir, vaniprevir, tigoprevir, which are all in phase 2, but these two are actually, boceprevir and tenofovir, have been now licensed and are available for treatment, but it is only for genotype 1. So when you look at the timeline, the numerous DAAs that are available now, if you look at the timeline here, we are here now. By 2013, this is now they call it the first wave. By 2013, you'll have several other drugs, and by 2018, they hope that we will be on just oral directly